This is going to be about certain organisms which are not very commonly seen in clinical practice. They form a small percentage, maybe less than 5% of all the infections that we see. First one being atypical mycobacterium, which was first reported by Turner in around 1965 and has been classified into different groups based on the growth. So if it grows fast, then it's known as a fast grower. If it grows slowly, it's known as a slow grower. And what we commonly see are Runyon group 4, which are the rapid growing mycobacteria like PYTHIUM and Chelonae abscessus. So usual risk factors for this would be, say, trauma, particularly trauma with a corneal foreign body. So foreign body that's been removed, there's an infiltrate there, and subsequently that increases in size. Also been known to occur after refractive surgery, sometimes even after cataract surgery. And usually these patients tend to receive topical steroids, and hence it tends to become, have a waxing and waning kind of a course. So what's been noted is that these form a very small percentage of the infections that we see. What was described in a very good review a little while back was that it occurs more commonly in males than in females, particularly when it occurs after trauma. It's usually unilateral, but if it occurs after refractive surgery, then it could be bilateral, and in that case, the right eye is usually worse than the left eye. So what do they look like? So they usually look like these multifocal infiltrates, and you can see the picture there of these large infiltrates. Sometimes has a cracked windshield appearance. Sometimes they may be satellites, so you have one single infiltrate and then these multiple smaller infiltrates beyond. The course is typically a waxing and a waning kind of an appearance. Now to diagnose it, we should stain, and what's important is to give the microbiologist a clue, because if you have an infection that's of a long duration, some of the organisms could be atypical mycobacterium, it could be nocardia, it could be acanthamoeba, it could be microsporidia. So these are the 4 organisms that we usually put on a requisition form, because if you give them a clue, then they know what to look for, because they're very, very small organisms and they may sometimes be missed. So this is how it appears on a slide. When you do a gram stain, you can see these small little gram positive or gram variable bacilli, and then when you do an AFB stain, you can see it becomes red on acid fast. Sometimes they grow very quickly. Like I said, if they're the rapid growers, it'll grow in about 2 weeks, but the slow growers take longer and require special media for growth. So the treatment, the first drug of choice is 2.5% amikacin. So you notice that when Jayesh spoke, he mentioned that we usually start a fortified cephalosporin and second generation fluoroquinolone, but we don't always start amikacin as the first line of drug. So this responds to amikacin. Second drug of choice could be a macrolide like clarithromycin, or even a second generation or third generation fluoroquinolone. Usually we end up giving combination drugs, and we never give topical steroids in this scenario. Now suppose it doesn't respond to therapy, then there are surgical options that are available. Now particularly following refractive surgery, in that scenario we would have, if it's following LASIK, if you have a suspicion of an infection, the flap has to be lifted, the bed has to be scraped, undersurface of the bed has to be scraped. We irrigate the interface with vancomycin and amikacin, put the flap back. Once we get the microbiology results, then we start treatment, which would be, say, cefuroxime and amikacin is what we usually start in those cases. The outcomes of treatment usually not very good, and about 65 to 85% do require surgery, particularly if they present you very late. Second is acanthamoeba. So in acanthamoeba in the West is commonly following contact lens wear, but in India, in the developing world, what's been noticed is that it's usually in agricultural workers following trauma with with soil or something that they work with in the fields. And in the Western world, it's like 80% is due to contact lens wear. These are usually unilateral infections, very uncommon, forming less than 2% of what we see in our practice. So again here, the predisposing factors are pretty much the same due to trauma or exposure to contaminated water and soil, the hot climate, or poor socioeconomic conditions. But it's also been noted after surgeries. We've noted some of these cases even after refractive surgery, so we have to be careful. So what's common here is that patients would have symptoms out of proportion to signs, but that's not always pathognomonic. They tend to have a radial keratoneuritis, that is an inflammation around the nerves, which is seen in up to around 28% of cases. The earlier features where it can be mistaken for HSV. So if you see this case here, so this has this kind of an epitheliopathy with some cellular reaction, okay? And this patient landed up being treated as HSV, and 2 weeks later develops this kind of a ring infiltrate. So therefore, if you miss it in the initial stages and treat it with steroids, then that's going to be detrimental. So it's good to have a high index of suspicion for anything that looks a little strange. Be very wary of starting steroids. In the late stages, ring infiltrates are seen in about almost 1/3 of patients, or it could be a very diffuse kind of an infiltrate. So diagnosis is fairly simple. If you have a KOH in a gram stain, These are what the spores look like, the Acanthamoeba cysts look like. On fluorescence, they look like this. On gram stain, you can appreciate this double-walled cyst, which has got a polygonal internal wall. And it's about 80 to 90% sensitive and specific for Acanthamoeba when you do these stains. Combine grams and KOH together. When we culture it on non-nutrient agar with an E. coli overlay. The Acanthamoeba feeds on the E. coli, and this picture below would show you what it looks like. So the cysts get converted to trophozoites. The trophozoites start eating the Acanthamoeba and create these tracks on the non-nutrient agar. You can also do a confocal microscopy, but that's like a 2 crore machine, so it doesn't make any sense. The drugs that are available for the treatment would be PHMB and chlorhexidine is what we get. These are swimming pool disinfectants, which are prepared in a concentration of about 0.02%. We usually use a combination. Way back in the 80s, we had done some studies which looked at the combination drug. Sorry, in the 90s, we looked at these studies which looked at combination works better than a monotherapy for Acanthamoeba. And in limited cases, we could use steroids. Steroids are indicated only if there's progressive vascularization, limbitis, and scleritis. But a word of caution, this is not the mainstay of treatment for Acanthamoeba keratitis. Now, in cases that don't respond well to therapy, we would have to resort to surgery. And particularly when you find that it's not responding to treatment and progressing towards a limbus, then you could do either a DALC or a full thickness penetrating keratoplasty. But the large grafts subsequently don't do too well. The other organism that we do tend to see, and again, which you need a high index of suspicion for, is microsporidia, which can cause different kinds of manifestations in the eye, ranging from a keratoconjunctivitis right up to an endophthalmitis. Previously, we were seeing more of bilateral cases, and literature from the West showed that these were immunocompromised patients. But now we are seeing a lot of patients who are unilateral and immunocompetent. There are epidemics where you find that it's more common in the rains. Predisposing factors in these cases would be exposure to contaminated water, people who work in the fields, very rarely contact lens wear. So this was a paper that came out of our center in Bhubaneswar, and you notice the number of cases that they tend to see. So this data shows you, let's go back, yeah. So this data shows you that in the monsoons, the number of cases that we see with microsporidial epithelial disease is much higher as compared to the rest of the year, but it's still a disease that you see throughout the year. So you have to be able to identify it very clearly. And when you see the keratoconjunctivitis, where you have lesions on the cornea that look like this, particularly these whitish epithelial lesions which appear that they have been stuck on the cornea, that's a characteristic feature of these coarse SPKs. You stain it with fluorescein, and you see that in sclerotic scatter, we're seeing this kind of a picture of these. It looks like a very beautiful kind of a starry sky appearance, but on fluorescein stain, this is how it appears. So these are intraepithelial lesions. Sorry, the whole thing went back, right? So on fluorescein stain, you can notice that these are very coarse SPKs. So what's important is to try and differentiate these lesions from the fine SPKs that we see with adenoviral keratoconjunctivitis. And I'll come to those differentiation factors later. So this is just to show you that these are all restricted to the epithelium. So this is a high mag. You can see that the stroma is absolutely clear. These white lesions that you see are all on the epithelium. So this is no-brainer microsporidial keratoconjunctivitis. Patients would have follicles. They may or may not have preauricular lymph nodes. They don't have petechial hemorrhages. They may have a serous kind of a discharge, present you with unilateral redness, particularly in the rains. And now, to differentiate it from adenoviral, you'd have follicular conjunctivitis with a discharge. There would be petechial hemorrhages. But when you look at the cornea, you find these fine SPKs, and that's the difference here. So you notice that the lesions here in adenoviral, they're all very fine SPKs. These lesions appear a week or even 10 days after the redness sets in, while with microsporidia, it almost occurs simultaneously, so there's no lag period there. When you stain the lesions also, these are fine SPKs that you see taking up stain on fluorescein. And when you have the subepithelial infiltrates, so you can compare the difference here, where you notice that there's this mild haze in the anterior stroma. This is because of cellular reaction, that is the subepithelial infiltrates that we see in adenoviral keratoconjunctivitis. So this is the actual differentiation. Adenoviral could be bilateral, but maybe asymmetric in the presentation. Fine SPKs with an associated subepithelial cellular reaction, which you don't see in microsporidia. There is congestion which occurs about a week or 10 days prior. They would have preauricular lymph nodes, petechial hemorrhages, pseudomembranes, and the latter, that is adenovirus, is due to an immunological reaction and requires steroids, but microsporidia has got the live organism in the epithelium, and it's a self-limiting condition altogether. So when you see it on IBCM, it's got a characteristic picture of hyperreflective intracellular dots. And when you scrape these lesions, the picture is very beautiful of these oval spores, which fluoresce very beautifully on fluorescent stain. But when you do a gram stain, because it can be picked up on gram stain as well, on gram stain you find these oval spores, and sometimes if you look very carefully, one end of the spore might be a little more stained than the other. It has a polar kind of a staining pattern. So, in the past, people have tried a lot of things for microsporidea. What is known is that it doesn't require anything. You can just use artificial tears. It resolves within a week or 10 days. But all these have been studied and have been proved that compared to placebo, anti-parasitic drugs or fluoroquinolones or antifungals, they don't work any better than just artificial tears. The stromal disease, now I've described the epithelial disease. Stromal microsporidal keratitis also occurs, and this is a great mimicker. It actually has a very prolonged history, like from months to years. The diagnosis is obviously delayed because you can't make out what it is, and it is commonly mistaken for HSV. So it has a waxing and a waning response. A lot of these cases have been treated with steroids, but they don't actually respond well. Again, the predisposing factors are common. And when you look at it, okay, it could look like acanthamoeba, it could look like HSV, it could look like atypical mycobacterium. So all these are actually microsporidia. So this is something that we need to be aware of, and unless you have a high level of suspicion, you may actually start treating it as something else and it doesn't actually respond. So these are the when you scrape it, how it appears. On scraping, you find again these oval-shaped spores, and when you do an acid-fast stain, you can appreciate the acid-fast spore on 1% AFB staining. In IBCM also, you can find these hyperreflective dots in the stroma. So now, management. Everybody usually resorts to surgery because fumagillin is a drop that's been prescribed but is not available in India and doesn't have a very good cure rate. The reason probably being that microsporidia has now been reclassified as a fungus, so maybe antifungals could work. There's only a few case reports out in the literature of antifungals working. There are some reports of drugs like chlorhexidine and PHMB working. We've got a few case reports from our own institute which have looked at that. So now we move on to the next organism, and this has actually been a learning period for us, where we have this patient who presented to us with this kind of an infiltrate. We scraped it, we thought it was fungus, didn't respond to antifungal therapy, landed up getting a therapeutic graft, and then after some time there was a recurrence in that graft, so we did a regraft, and the regraft also had a very bad recurrence, and then another graft, and now this graft is finally okay, but it's failed. So what we learned down the line was that this was not actually fungus. This was an organism known as PYTHIUM, and PYTHIUM insidiosum is actually a parafungus, and it doesn't have the chitin in the cell wall like normal fungus has. So when we treat it with antifungals, it just doesn't work at all, and therefore it just keeps on worsening and lands up with a corneal graft, which doesn't do so well because you treat with antifungals thereafter and it comes back. So PYTHIUM has actually been found in the soil and in the water. It's kind of like an ubiquitous organism, more in the tropical areas. It was first described from Thailand, and what they noticed was that the people who were working in the fields, particularly in the paddy fields, were the ones who were most infected with it. There are these two forms that we note. The upper picture shows you a zoospore, and the lower one shows you these sparsely hyphate filaments. It can cause human infection in 4 forms. Most common being keratitis, and about in the eye it's about 33%. Systemic disorders, as you see the pictures below, would be around 60%. You have systemic disorders or vasculitis. Can cause skin infections and can get disseminated and cause infection in the entire body. The risk factors again are exposure to contaminated water for both the eye as well as the skin systemic features that we see. And I'll move on to what we have learned about this organism. So we've learned that it actually has a picture which is very much like fungal infection, but with a difference. So you notice that there are these feathery borders, which are similar to what you see in fungal infection, but PYTHIUM has got these tentacles, and we learned about the tentacles when reviewing a lot of cases in Hyderabad. They noted that it has these tentacle-like extensions into the stroma. So this may be mistaken for fungus, and then when you scrape it, it looks very much similar. So when you scrape it, it looks like this. So these look like broad septate hyaline filaments, right? But the thing is, it's different because it has this kind of a ribbon folding, if you notice here, and there are very few septae, so it's sparsely septate. So that's something that we need to keep in mind and probably inform the microbiologist that if they see sparsely septate filaments on a gram or a KOH stain, they have to keep in mind that it could be pythium. And I'll show you the image of what fungus actually looks like on KOH. So it looks like this. So you notice there are many septae in this image, and there's no ribbon folding that I showed you earlier. So this is a differentiating point between the two. So you see them side by side, so you can appreciate the difference. These are broad, ribbon-like aseptate, and these are narrower, no ribbon folding, and there are many septae that you can appreciate, plus the branching. So in culture, what does it look like? So it has this flat kind of a growth in culture, and that's why we are not able to pick it up very easily. It doesn't grow so well, but when it grows, it looks like this. And you see on blood agar, there's this kind of a very flat growth on the culture plate here. And as compared to fungus, where you see this cottony kind of growth on blood agar. So it can be observed. You can demonstrate a zoospore formation using a very complicated technique with a carnation leaf, and a new staining technique that's been described using 60% H2SO4, where it looks blue. And you can appreciate this picture on top here, where you can easily appreciate pythium, but fungus does not take up that stain. So you can also sequence it using a sequencer. And as far as the treatment is concerned, if you look at a review of the literature, in the past, everybody treated it with antifungals, and you notice that most of the cases landed up in penetrating keratoplasty, and the outcome was not all that good. So none of them responded, actually. But what's been studied is the in vitro synergy. It's been noted that they have a response to macrolide antibiotics and dual drug therapy. So with that in mind, when we look at this paper that showed that azithromycin actually worked very well, and if you see this graph here, which is azithromycin, shows a very good response to azithromycin in vitro studies. There was a paper that was published from our institute where the first case of Pythium insidiosum was described, which responded to topical linezolid and azithromycin along with oral azithromycin. So you see how the infection has resolved within about a couple of weeks, not weeks, months actually, of therapy to a resolution with a complete scar. And subsequent larger series of cases looked at the same kind of data, where you see that in the beginning it was all therapeutic grafts formed the main part of this, and gradually the number of therapeutic grafts has gone down. There's some more data that's coming out, and some have actually healed, though it was just 25% of the cases which healed. But over the last 3 years, from 2016 to now, we still have more cases of Pythium which have healed. So this was data from Hyderabad. When we looked at our own data of 16 cases, we noted that 5 of these patients had to resort to a corneal graft, but these are the ones that presented to us with very large infiltrates and perforation. But we didn't have to eviscerate any, and about 50% of this data healed. Subsequent to that, we have a couple of more cases which have added, and the success rate is close to around 70%, which is good for an infection of this kind. So I've not shown nocardia, but I'd like to sum up by saying that unless we have a high index of suspicion for these atypical organisms, we scrape patients who have got a long course of treatment, and we inform the microbiologist that we're thinking of these atypical organisms. It's very difficult for the microbiologist to tell us that it's there. And subsequently, the management is tailor-made to each bug. So therefore, the treatment would vary for each organism, and the outcomes would differ based on that. Thank you very much. Oh, really? You don't? Oh, okay. Sorry. Oh, okay, okay.